Are you a therapist, clinician, case manager, or other mental health provider? If so, stick around as we discuss borderline personality disorder and the importance of its destigmatization in the mental health community. Borderline personality disorder is described in the DSM as a pervasive pattern of instability in interpersonal relationships, self-image, and emotion, as well as marked impulsivity beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following: chronic feelings of emptiness, emotional instability in reaction to day-to-day events, example, intense episodic sadness, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. Frantic efforts to avoid real or imagined abandonment. Identity disturbance with markedly or persistently unstable self-image or sense of self. Impulsive behavior in at least 2 areas that are potentially self-damaging. Example, spending, sex, substance abuse, reckless driving, binge eating. Inappropriate, intense anger or difficulty controlling anger. Example, frequent displays of temper, constant anger, recurrent physical fights. Pattern of unstable and intense interpersonal relationships characterized by extreme idolization and devaluation. This is also known as splitting. Recurrent suicidal behavior or ideations, gestures or threats or self-harming behavior. And lastly, transient, stress-related paranoid ideation or severe dissociative symptoms. While there is no clear, hard evidence that explains the exact etiology of borderline personality disorder, there is a clear consensus among researchers that contribute causation to genetic, neurobiologic, and psychosocial factors. There's moderate evidence for genetic transmission and heritability, especially when combined with trauma exposure. Genetic predisposition with twin studies shows that BPD has over a 50% heritability rate. Childhood trauma is often a contributing environmental factor for BPD and is found in 70% of people with the diagnosis, including sexual, physical, mental abuse, neglect, maternal separation, poor maternal attachment, inappropriate family boundaries, paternal substance use, and serious parental psychopathology. Nearly 1/3 of people diagnosed with BPD have been raped or sexually assaulted. The mentalizing model attributes that BPD is a result of a person's inability to reappraise negative events, which leads to accumulating bad experiences and failing to learn from good experiences. Dr. Marcia Linehan's biosocial model proposes that BPD occurs due to a combination of genetic vulnerability and a chronically invalidating environment during childhood. BPD could be a result of a person's inability to regulate and form appropriate coping mechanisms. Attachment trauma, especially with the primary caregiver, is likely a contributing factor of BPD. Neuroimaging studies identify that BPD impacts the amygdala, hippocampus, and mediotemporal lobes in the brain. These same studies found that people with BPD are more likely to interpret neutral facial expressions with negative emotions like fear, anger, and disgust. A 2015 study suggested that serotonin dysregulation reduces the sensitivity of the 5-HT1A receptor and may be a contributing factor to borderline personality disorder. According to another study published in 2005, people with BPD had impaired neurocognitive performance in attention, cognitive flexibility, learning and memory, planning, speed processing, and visuospatial abilities. Additionally, increased rates of learning disorders, ADHD, and neurocognitive deficits have been reported in people with a BPD diagnosis. Borderline personality disorder is one of the most commonly misdiagnosed mental health conditions because people with BPD typically also meet the criteria for multiple other diagnoses. There is a comorbidity rate of 80 to 96% for mood disorders, 88% for anxiety disorders, 64% for substance use disorders, 53% for eating disorders, 10 to 30% for ADHD, 15% for bipolar, 10% for somatic symptom disorder. According to Dr. Alan Frusetti with the National Alliance on Mental Illness, these disorders are not independent of BPD, but are connected and related through shared psychological, social, and biological pathways. However, when these diagnoses are the focus of treatment, they can dominate professionals' attention, preventing any significant focus on the whole pattern of difficulties, resulting in misdiagnoses of BPD. There is evidence that borderline personality disorder is commonly misdiagnosed as bipolar 2. One study showed that 40% of people who met criteria for BPD but not for bipolar disorder were still diagnosed with bipolar type 2. This is most likely due to some similarities between symptoms, namely impulsive behavior, intense emotions, and suicidal thinking. However, they are very different diagnoses with different treatment methods, so it's crucial that mental health professionals understand and know the difference. Additionally, as mentioned earlier, there's often a direct correlation between childhood trauma and borderline personality disorder, which can result in large overlap between symptoms of BPD and trauma reenactment behaviors, as well as PTSD and CPTSD. Again, the treatment implications and protocol between these diagnoses are different and specialized. But also, BPD is so stigmatized in the mental health field that a BPD diagnosis can increase the potential for discrimination and limit recovery outcomes. Because of this, it is extra important that clinicians be mindful to discern whether or not a client's symptomology is a result of borderline personality disorder or if it's a result of unintegrated trauma. To avoid stigma and its impact on outcomes as well as misdiagnoses, clinicians are urged to spend some extra time getting to know a client and their possible trauma history, especially before making a diagnosis of borderline personality disorder. As well, clinicians are encouraged to consider if a client's symptoms are more reflective of PTSD. BPD is one of the most heavily stigmatized mental health conditions a person can experience. Some mental health professionals are reluctant or even refuse to diagnose or treat BPD even when a person clearly meets diagnostic criteria. This problem is even more pronounced among adolescents. Many clinicians fear that even correctly diagnosing a teenager with BPD will only worsen their problems because of stigma. In addition, many professionals incorrectly believe that it's not possible to diagnose BPD in adolescents. This results in underdiagnoses and inaccurate prevalence rates. Worst of all, it prohibits teens from receiving the specialty care that they need when early detection and early intervention are essential to recovery. Some of the problems with diagnosing result from the fact that there was no evidence of effective treatment for BPD until the 1990s. Today, unfortunately, many professionals continue to think that BPD is not treatable despite growing evidence that it is. This leads some professionals to avoid giving the diagnosis even when someone does meet the criteria. Borderline personality disorder is so misdiagnosed that there is much debate and no clear consensus on its prevalence. Let's break down some stereotypes and learn about actual prevalence rates. Surveys estimate that 1.6% of the general U.S. population has a BPD diagnosis, with a lifetime prevalence of 5.9%. 20% of inpatient psychiatric population have a BPD diagnosis, and 11% account for outpatient. There's no significant difference in diagnosis rates between males and females in the general population. However, females were represented 3-to-1 in clinical settings, suggesting that men are more likely to go underdiagnosed, misdiagnosed, and are less likely to seek treatment. Much of the stigma surrounding BPD is about perceived high rates of suicidality. The actual reported rates of suicidality are 3 to 6%. The mean age of suicide ranges between 30 and 36 years, and it's not the young frequenters of ER visits that we often imagine. Nearly 1/3 of youth suicides, mostly male, can be diagnosed with BPD via psychological autopsy. Other studies also support that males with BPD are more likely to die by suicide and less likely to receive treatment. A series of studies were conducted with Black and white women who had BPD. Suicidality and self-harm was more prevalent in white women. They found that the Black women studied were less likely to self-harm or attempt suicide, which are often the hallmarks of BPD. Because they primarily presented with symptoms of anger and aggression directed at others versus the self, they were less likely to be referred to appropriate mental health services or admitted to inpatient hospitalization. Because their symptomology often didn't include self-harm, many of the Black women studied had been misdiagnosed with bipolar 1, for which treatment heavily relies on medications that are known to be significantly less effective than specialized psychosocial and psychotherapy for treatment of BPD. The established correlation between borderline personality disorder and increased trauma exposure, combined with stigma and distrust of mental health systems, BIPOC and other marginalized individuals may be severely underdiagnosed. There are many mitigating factors like systemic oppression, racism, and other cultural norms that make it challenging to ethically determine prevalence among these groups, and additional research is needed. When it comes to treatment for BPD, many providers may assume that DBT is the be-all, end-all, and while it does prove effective in many cases, it is often considered best practice for treatment. There are other evidence-based therapeutic intervention models, including mentalization-based therapy, transference-focused therapy, schema-focused therapy, general psychiatric management, structured clinical management, systems training for emotional predictability and problem solving, and standard cognitive therapy. Because individuals with BPD are much more likely to experience suicidal ideation and exhibit self-harming behaviors, providers are strongly encouraged to complete safety planning with their clients. Short-term hospitalization is not supported by evidence when suicidality is chronic. However, some studies suggest equal improvement among patients with or without BPD with prolonged inpatient hospitalization that is lasting more than 1 week. Recent evidence supports that suicidal patients with BPD are most likely to benefit from outpatient specialized forms of psychotherapy, with the best outcomes attached to meaningful relationship building and therapeutic rapport. While short-term hospitalization is shown to be less effective for long-term recovery, it is required when there is imminent risk of highly lethal behavior due to suicidal ideation or impulsivity, when we see severe social stressors that cause intense negative emotions or transient psychosis, when there is a rapid increase of severe self-injuring behavior, or an increase in severe substance use or self-harming coping mechanisms. Research supports that recovery is possible and even likely in individuals who undergo long-term treatment, with a prognosis rate of 35% remission after 2 years, 91% remission after 10 years, and 99% remission after 16 years. It is important to note that remission rates may be reflective of participants' increased avoidance of interpersonal relationships. Faster remission is more often achieved by individuals who begin treatment under 25 and with a higher baseline functioning level. They are also typically less impacted by comorbidities and do not have a history of childhood trauma abuse or familial substance use. People with borderline personality disorder have a smaller window of tolerance, meaning that they, like the jar on the right, often begin their day nearly at capacity. People without BPD are like the jar on the left. They have emotional space for ambiguity, nuance, and are less likely to overflow when the world hands them challenges or perceived criticism. The following is a poem written and read aloud by Whitney Hansen, whose TikTok is linked in the comments along with all other references.
Do you ever notice how you can fill a glass of water a little bit higher than the rim of the glass, and the surface tension holds it all together? But you add 1 drop too many, and a puddle spills onto the floor. I think that emotions are kind of like that. You can exist in a state of tension for so long, but eventually 1 drop is all it takes to make you overflow. I guess that my point is, The drop that breaks you often has nothing to do with the 1,000 that filled the cup. You cannot accredit your overflow to a single drop, and you can't accredit your reaction to a single incident. Remember how long that you've been waiting to overflow.
People with borderline personality disorder tend to be unpredictable and have heavily saturated emotions. They are overflowing. If we're not mindful, we can look at the tip of the iceberg and dismiss what might be going on beneath the water's surface. When it comes to working with individuals who exhibit symptoms of BPD and trauma reenactment, it's vital that we take the time to discover what lies beneath the surface to ensure an accurate diagnosis. We can increase our empathy and compassion by remembering that there are likely layers of childhood trauma and years of invalidation that brought the person in front of us to be chronically dysregulated and spilling over. When we fail to become aware of our own internal bias, we can no longer distinguish what is the nature of the pathology and what is the nature of the individual. We lose our neutrality and the ability to genuinely connect with our clients. We are more likely to gaslight them by minimizing symptoms and overlooking strengths. When we emotionally distance, the client is likely to pick up on it, which can unintentionally affirm their fears of rejection or abandonment. This can result in undesirable outcomes, increased self-harm or harm to others, as well as amplifies the potential for suicidal ideation. It may even cause the individual to leave services or give up on treatment altogether. It is vital that we destigmatize ourselves and our field with continued education and research as we individually commit ourselves to the consistent and authentic unconditional positive regard that is perhaps the most important factor when working with individuals with higher rates of trauma exposure, and especially those living with borderline personality disorder. As providers, it is our work to walk alongside our clients on their journey to recovery and to hold hope for them even when they